Well, welcome everyone to our breakout session about how critical access hospitals and rural health clinics can address mental health and substance use in their communities. My name is Tracy Morton. I work for the National Rural Health Resource Center. So I'm just going to do a quick overview of how to use the room that we're in right now, and then I'll introduce to you the objectives for our session here and the speakers. So we're in a different room than we were before, but all sessions are still being recorded. If you have any technical difficulties, we encourage you to use the chat box, access at the bottom of your screen, and our staff, as well as the staff that perform media, are monitoring that. We also encourage you to ask questions and interact with the presenters. So during the session here, if you have a question, please use the chat box. You can also verbally ask a question by muting and unmuting your microphone. But we do ask that if you aren't speaking, that you keep your microphone muted so we reduce any background noise. So with that, again, our session today is about how critical access hospitals and rural health clinics can address mental health and substance use in their communities. We hope that by the end of this session, you'll be able to replicate some strategies and frameworks that CAHs and RHCs can use to address mental health and substance use. We hope that you can examine opioid prescription reduction and successful outcomes from the Hopi Tribal Department's law enforcement and Hopi Substance Abuse Prevention Center collaboration. So joining us today as speakers include Dr. Darren Vicente, who is a graduate of the University of New Mexico School of Medicine, and he completed his residency in family medicine at the Southern Colorado Family Medicine Program in Pueblo, Colorado. He has experience with the Indian Health Service for over 20 years in family medicine, and he began his career with IHS as his original goal starting out of med school at the Santa Fe Indian Hospital. He's been at the Hopi Healthcare Center as the chief medical officer for over 18 years. He's from the Hopi and Zuni tribes, and he's committed to population health management for his unique tribal communities, utilizing one of the best tools and models for healthcare delivery in the United States, and that is the Indian Health Service. I personally have some experience with IHS, and I completely agree with your bio there, Dr. Vicente. Also joining Dr. Vicente today is Kenesha Kuniptawa, and she is a community health representative with the Hopi Tribe Community Health as a community health representative in the CHR program there. She's on the front line of public health workers and has over 7 years made herself an expert in patient care to ensure the welfare of her community members from infants to elderly. Ms. Konekwa is currently an instructor for the Chronic Pain Self-Management Program, and she's a member of the Hopi Healthcare Center Chronic Pain Management Committee. Kenesha is an enrolled member of the Hopi tribe and currently resides in the village of Abbey. And she has 2 children and is of the Coyote clan. So thank you so much for being here. We appreciate you joining us to share your information today.
Thank you for having me today.
Excuse me, I'm sorry,
Good
Tracy.
morning.
This is Angie. John is here, so we could introduce John as well.
Okay, great. We have a third presenter as well today, and that's Dr. John Gale. He's a senior research associate at the Maine Rural Health Research Center. His work there focuses on rural delivery systems with rural health clinics, CAHs, mental health, substance use, primary care, emergency medical services, as well as program outcome measurement and evaluation. He's the principal investigator for Maine's work with the Flex monitoring team and the Frontier Community Health Integration Project demonstration, or the FCHIP demonstration. He's worked with CHs in the Flex program for over 20 years. He's involved with lots of different national boards, as well as boards in the New England area where he resides. He's part of some technical expert panels about quality improvement as well. So with that, I will turn it back over to our speakers.
And this is Angie LaFlamme. I'm sorry, I'm going to interrupt one more time. Dr. Vicente and Kenesha, if we could have you present for roughly 20 minutes so we can leave 20 minutes for John.
Okay, fantastic. All right, well, good morning, everyone, and thank you for this opportunity to share a little bit of what we do here in our part of the world. So the Hopi Indian Reservation is located in northeastern Arizona. For those of you familiar with Arizona as a state, there's a lot of activity in the state of Arizona, which would be primarily in the southern half, with Phoenix being the 5th largest city in America, and then Tucson, where the University of Arizona is. But northern Arizona is pretty vast and mostly open, and we are right in the middle of the Navajo Indian Reservation, and so we are fortunate as a IHS facility to be able to have a lot of resources to be able to address issues. Historically, here at the Hopi Healthcare Center, we have used a population health model that allows for us to have a clear understanding of who we are as a critical access hospital, what we need to do to maintain our levels of accreditation. We have a moderately complex CLIA accredited lab. We're a Joint Commission accredited facility. We're a Joint Commission accredited primary care medical home. So it's all about using the tools that are available for us to be able to meet the needs of our community. I'm honored to do the presentation, but I would be remiss if I didn't mention that the original presenter of this was Dr. Kendra Johnson. I've shown that here in the slide. She was a family medicine physician that was here with us, recently left the service unit after she got married, and we wish her the best of luck, but she was an outstanding and invaluable contributor to what we've been able to achieve and what I'll be sharing here in our presentation. So the objectives here are to simply review opioid overdose impact in rural and tribal communities in Arizona, share some of our successful strategies. We feel that we've had a highly effective, and therefore we want to highlight the non-opioid strategies that we've used for pain management. And then Kanisha is here representing in a very meaningful way the collaboration that we have with our tribe to be able to meet this objective. So graphs that many of us have probably seen, the accidental drug overdose epidemic across America is a significant issue. This graph is produced by the CDC, and we've all seen this graph, and it is concerning. So what is seen in the country, as we always state here when we have conversations at our hospital, what you see in the news, what you see going on in the country, most vividly outlined right now that we have COVID-19 issues in our community just like everywhere else, but the opioid epidemic was clearly an issue for us out here. What you can see here are stats that clearly show that from a race proportion, it's been long known, even before these stats were released, that we have issues with opioid and substance abuse addiction issues in our community pre-existing. So the arrival of opioids and the impact of opioids in our community really allowed for us to look at what's going on. So when you see national data that reflects that Native American communities are being significantly impacted by opioid addiction and opioid overdoses, we definitely use this information to look specifically in our community on the Hopi Indian Reservation to see exactly what's going on. So, as you can see, and I just mentioned the Native American population is a huge component of this. Here's a visual of who we are as a Hopi Healthcare Center, and so the Hopi tribe is located right here with the much larger Navajo Indian Reservation, and we are about 100 miles northeast of Flagstaff. And so we have an issue of, in our region, and working with state universities and looking at our state data and working with the Arizona Department of Health, as well as with the University of Arizona Rural Health Association, we have looked at data to look at fatal overdoses involved with prescription opioids. And as you can see here with the graphs, we recognize that we have had issues in our region and within our state, and we definitely wanted to use all of this information to come up with a meaningful plan for addressing this issue in our community. Again, a larger scale visual here showing that the United States opioid sales from the year 2000 to 2017, again, it's clearly an issue, and although the graph is starting to look like a downward trend in a positive way, we feel that here on Hopi we were able to recognize this and really do a stronger job of addressing this issue. You look here and you see the states that have been impacted, and Arizona is number 8, and we were very committed at the Hopi Healthcare Center in alignment with our primary care initiatives and our population health management objectives of making sure that we were able to contribute not only to the state of Arizona data, but to our community in a meaningful way to ensure that we prevented this in our community. So this is a CDC graph again from 2017, the number of prescriptions per 100 persons. Hopi would be in this slice up here, which puts us in the range of 57 to 82 per 100 persons. So again, we recognize that data is starting to look meaningful in our community, so we had to do something about this. And again, just a larger graphic showing our area here. This is a county breakdown in Arizona, and we are in Navajo County, which is not listed, or it's listed right here. So again, using this data to reflect exactly where we're at and tailoring this data to address the issues within our community specifically. So we wanted to be definitive in how we started. So as with everything, you form a committee. So we identified a chronic pain management committee. We identified leadership, and this would be a combination of our pharmacy staff because they are definitive partners in prescribing and management of prescriptions here. And then we had a medical staff leader, which was Dr. Johnson, as aforementioned. We had to identify which partners we wanted to have. And again, meaningfully, you want to do this. You can easily state that you want to have collaborations with individuals or entities, but really it's important, especially in a small rural facility, to clearly identify who your partners are going to be. The University of Arizona is a big partner. As you see here expanding, we have identified a lot of these entities. So it's important to note that locally, we not only identified these entities, but we identified specific individuals who would be meaningful contributors and partners in our collaboration as we started to go forward. Everybody had a different level of resource, and that's what we were working towards. So we focused on the fact that we had to do education. We had to start with our providers because they are the original prescribers. So as many of us are probably aware, the medical staff is not your only prescriber of opioids. We recognize that there are other care departments in our critical access hospital. So we involved our dental staff in this training and education. We involved our optometry staff because it was an important opportunity to drill down to our prescriber level, recognizing that it doesn't need to be a reflexive thing, and it definitely should not be an automatic thing that we are prescribing an opioid for routine dental procedures, for routine eye exams, and even in the setting where patients are asking, we felt it was very important that our providers recognize that there are definitive alternatives that have been proven by science to be equally or even more effective, and we should not be prescribing at these levels. Provide quality evidence-based alternatives, as I just mentioned. And so we did a lot of deep dive literature searching. There's a lot of fantastic literature that's out there right now showing the benefits of NSAIDs and showing the benefits of other alternative pain management strategies. We built an acupuncture program at our facility, and then we recognize the importance of working with our partners to develop a community-based chronic pain self-management program to truly get patients involved with this. We had monthly meetings with our stakeholders. We had to partner with our pharmacy to explore avenues of how we can get lockboxes out in our community. We partnered with law enforcement to make sure that there's education being provided out there. We provided education to our law enforcement partners to be able to use Narcan and have those resources available. So we were able to do all of that. Aggressive radio campaigns, we had flyers created, and we really worked hard to get this education out there, and we partnered with the University of Arizona's Department of Rural Health to collaboratively organize a Red Ribbon Run, which was historically done here for substance abuse issues, but we wanted to make sure we included the issue of opioids, and we wanted to recognize treatment of opioid abuse and dependence, and we also expanded through our medical staff training to have Suboxone as a treatment option here. So I'm just highlighting what's going on. This is a typical Hopi Healthcare Center sunset. So as we identified our members within our service unit, we really wanted these members of the community and our hospital team to be the drivers to be able to assure that we consistently provide the level of education and hit it at multiple tiers so that it's not just a top-heavy clinician-driven, we're going to say no, we're going to pull these resources away, but more a collaborative effort from the very beginning and onset to be able to ensure we're reaching the layers and the dynamics of our community. We, as a critical access hospital located in our region on the Hopi Reservation, using a population health model, know what the social determinant of health issues are for our community. We know how to use our resources, and we know how to partner with our tribal partners to address these issues. The community health representative, who you'll hear from here in a bit, very important as these program representatives are able to go out into the community. They go out by village. They can go directly to the patient home, and they are an invaluable resource for our community in any type of clinical situation. We standardized policies. We reviewed individual patient cases to really look at what we're doing. So we have the luxury of having a pharmacy here that can run data. So we knew all of our patients that were getting opioid prescriptions. Now, this is an inherent thing that is valuable and important, and I just wanted to share a little bit more detail about this because our patient population comes to our pharmacy. So within our community, we're in essence the only pharmacy in town. Patients do have options to go other places, but with the advent of the prescription drug monitoring programs, we're now able to look at where patients are getting medications. But as a very powerful tool for us, knowing our pharmacy had data on every patient that were getting their medications from here, we were able to identify the individuals that were exceeding 100 morphine equivalents. We were able to identify the patients that were consistently getting higher volumes, frequently asking for refills in a shorter time period, and that provided an invaluable starting point for us to be able to launch our strategies rolling forward, to be able to do things. So after our provider education, and as mentioned, the Arizona Prescription Drug Monitoring Program, we built into policy and protocol here that you have to look at the PDMP report before you consider writing prescriptions. So even in the emergency department, if I'm seeing a patient who fell off their ATV, for example, and has an acute fracture, I will still look at the Prescription Drug Monitoring Program database to make sure that if I'm looking at starting an opioid for a very short, limited course, that I had the overall information. We did a lot of education, as I mentioned earlier, about the alternatives. We looked at data that shows nationally that there are effective uses of NSAIDs, and they are equally, if not more, effective at pain management. And we really stress this with providers. You don't have to start at the opioid level, and you definitely have meaningful strategies that you can use. And again, the outbreak and the epidemic across the country for opioid deaths really allowed for meaningful studies to be utilized and updated. We limited through our pharmacy by quantity. So the most you can get is a 3-day supply. The maximum number of tablets you can get is 12. We designed that internally, and we educated everyone that this is what you're going to get. So you can't stack your prescriptions. You can't say, well, I need to give 2 3-day amounts. By policy and by creation here, you can only give limited quantities. And for our after hours in the emergency department, you're limited at the total number of tablets that you can get. And then you have to be immediately backtrack and linked with your primary care provider for review and for discussion. And again, just showing, as I mentioned before, a lot of literature out there about alternative methods compared to opioid use when you're dealing with things even as significant as acute fracture pain. Here's just a example of the type of education that we've used. So this is not only used here in our care departments. We share this with our patient population when we institute a drug contract with our patients. We share this information up front. We ensure that there's adequate counseling to have this there. These posters are displayed throughout our entire facility, both in the urgent care ER setting as well as in all of our primary care rooms, to make sure that there is consistent access to this education. As we continued with our provider education, which was continuous, and again, another example of how we're using up-to-date medical literature out there and not only driving it by policy and procedure here. We had to do this to be able to address this issue, and again, continually reinforce that there are non-opiate alternatives for pain management. We updated our controlled medication agreement. We make sure that there is long-standing multidisciplinary education with our patients as they enter into these agreements, talking to them about the risk, talking to them about the risk of addiction, and talking to them about alternative management strategies that could be implemented. So one of the things that we did through policy is the urine tox screens. So this doesn't always have to be provider driven. If a patient is under a pain management agreement, we have standing orders and protocols to allow for a pharmacist to order a UTox or any other healthcare provider who understands our care pain management program here. We don't allow for any narcotic refills out of our emergency department, and those can only come through our primary care department. The state of Arizona's PDMP program allows for quarterly reports that get provided to each provider. This is then brought to me as Chief Medical Officer and reviewed, and then we incorporate it as part of our peer review here at the service unit. And then we also do yearly patient chart reviews to make sure that we're managing things appropriately, and this is done by our Chronic Pain Management Committee. So what this resulted in is a plan for us to be able to start slow tapering plans. So if we have a big picture understanding of what we're dealing with, then we can really start to put forth those strategies. All of the partners were involved in doing this, and we were able to come up with significant strategies to help us address issues. I mentioned before that we had provider interventions and education for our dental clinic, recognizing that dental is a potential resource, and I can just tell you that our dental department has been 100% on board, and we saw a immediate 74% reduction in prescriptions for opioid medications within our dental department in short order. So what you're seeing here is really kind of the quintessential display of what we've been able to achieve. So if you look at the timeline there from July through December of 2015, we clearly had a lot of prescriptions. Here's a listing of all the different medications that we had on formulary, but clearly we recognized back in 2015 that we have an issue, and as we started organizing and structuring our approach and used a collaborative multidisciplinary approach, you can clearly see that through the end of 2019, we were able to have a substantial reduction in the amount of opioids being prescribed out of our primary care settings, out of our acute care settings, out of our ancillary department settings, and clearly this reflects that there are less opioids in the community. When we run our PDMP reports, our patients are not going to alternate facilities to try to get access to pain management medications. They're actually getting all of their care here, which we believe is a reflection of the work that we've been able to achieve. Alternative therapies include acupuncture that we started here. We have our behavioral health program and our social services program that are part of this. And then we have our new chronic pain self-management program. And I'm going to turn it over at this point to our community health representative lead, who's been integral in getting to this point. Kanisha?
I work, like I was stated earlier, I've been with the Hopi Community Representative Program for a while now. There are, CHRs that come from that service different villages. Right now, myself and another CHR are currently assisting the Public Health Nursing Department with, services to the communities for the COVID-19 right now. So what we do is we're comprised of, healthcare providers. We provide follow-up and continued contact with the healthcare delivery system. What we do is, to provide, health promotion and disease prevention services to Native Americans who reside within the Hopi communities. Our chronic self-pain management program is a small work group session. It's usually about 2 to 2.5 hours, one session per week for 6 weeks. One session we had in progress until the COVID-19 shut down, and we had 7 participants. So we were in the middle of our classes. We were doing follow-up calls to see how they were doing, and just case management, just to make sure that they're okay and that they're staying on track, with their plans that they had in place for themselves. I'm pretty sure once we start opening up the healthcare again, we'll get with these people so that way we can continue with the sessions if they're still interested. Topics covered within the within the chronic management program is, techniques to deal with problems such as frustration, isolation, fatigue, and poor sleep. The Moving Easy program, that's part of the chronic pain management book. Communicating effectively with family and friends and health professionals, meaning, it's okay to ask more questions when you are in with your medical provider. Pacing and activity action planning and rest, and how to evaluate new treatments, breathing treatments, using the breathing technique, acupuncture, and different models of self-management. Our participant experience. So this is a quote that was written to us at the end of our second successful session. The lady, she was really quiet. She just stayed at the front of the right there by the door. She didn't like the door closed. So we have different accommodations for different people who are in our program. But this is within the time that we've seen her to when she first started to, when the class ending, she became really self-efficient. She was really taking the book into, part of her daily routine and moving things around. So this is a quote that she wrote. I thought I knew a lot about myself, but I was wrong. When I started reading the book, I discovered several things I have not tried. I didn't know how to plan my activities, set goals, or choose the food I ate. Using the action plan form, she found it very attainable, even if your confidence level is low. It just makes you want to do it. I want to thank you all for listening and understanding the pain we deal with each day. I wish you all well and continue helping others. And like I said, at the beginning of the program, she was really quiet. She just stayed in the front of the room, and she didn't really say much. But as we see these people over time, they give you that good vibe, and you end up, creating this bond with them. So they were, she was really grateful, and she was one person that really, took this and was able to incorporate it in her daily activities at home. So our community outreach, we had in-home medication disposal with the doTERRA bags that we were given. We have 2 community sites for medication drop boxes, which is here, the Hopi Healthcare Center at the Hopi and at the Hopi Law Enforcement Services Program. We had a very successful Red Ribbon Run in October 2019. 4 radio programs that was run by Dr. Johnson in the past, as well as a presentation to Tribal Council in 2018 and outreach at the 100 Mile Lunar Club for the last 2 years. With with the COVID situation going on, we were unable to do outreach at the 100 Mile Club as everything was virtual. So this was just some pictures of our presentation from last year. So community outreach and community safety medication disposal. With, over the years, this was last year, we had discarded over 10 pounds of medications while on home visits. So these medications that are right here on the table are from a client. So we, that we were able to dispose of the medication properly, which is a lot. In many households out here, especially when you're doing home visits, you'll see the amount of medication that's right there on their tables because, they just don't know how to get rid of it, or, they just think they'll use it in the future. So these are community outreach and community safety medication disposal. As I stated, the Hopi Tribal Law Enforcement Services has a medication disposal box at their office. In the past, in 2018, they were able to dispose of 34 pounds of medication from the community members. In April 19, they didn't get any medication. In January to present, over 80 pounds of medication have been taken back through the medication drop box at the Hopi Resource Enforcement. The medication return box is also available at the Hopi Healthcare Center, and it is advertised on the Hopi Litivani and the Navajo Hopi Observer, which are local newspapers. So this was the 2019 Red Ribbon Run for substance abuse, which was held here at the Hopi Healthcare Center. So, and on October 26, 2019, it was a theme costume. So there's a poster right there of, the Monster Dash. 14 educational booths were present, and we had 250 participants range from 2 to 74 years old. So this took place in the early morning. We were surprised for the turnout because we had a ceremony that day, but we were, really surprised at how many people came and participated for the event. This is just another picture of the staff members that were there and the resource booths. Media outreach. This was like Dr. Johnson's house calls, pain management committee, medication safety, substance abuse prevention, and medication safety, and the presentation to Tribal Council. Youth outreach, unfortunately, we weren't able to do a lot of youth outreach due to, COVID and this situation, but last year or 2 years ago, they were able to do a spring break event. And last year, the Red Ribbon Committee was able to do a float at the Hopi High School homecoming parade. Outreach at 100 Mile Clubs, I pointed this out. We weren't unable, to do that this year. We usually do it at the lunar event about presentations, but this year we weren't able to. So these are just some pictures of what we did last year. And that's the end of my presentation part.
In brief summary, this is our model that we're using here. This is Hopi at Sunset, but we feel that we've been quite successful here. Kanisha's presentation represents how important it is to have the community component, because they're able to get out to the patient homes and they're able to motivate the youth and get education campaigns out to the communities one by one. But we've had a very successful model here, and we'll be more than willing to answer any questions at any point via email or at the end of this presentation. But I'd like to turn it over to our other co-presenter at this point.
There we go. Try to do this as quickly as possible. I'm going to talk to you a little bit about the work that we've done with providing mental health services in CAH-based rural health clinics. For those of you that don't know me, in addition to working with clinics and mental health and integrated care in the research world for 20 plus years, I managed psychiatric and physician practices, psychiatric and primary care physician practices for 16 years before that. So I've had a lot of experience with integration. So I'm going to talk about some of the benefits of doing this through an RHC, key decision points, and some of the rules and regulations regarding mental health services. The slides will be available. I don't know how much we'll be able to get through, but I'll be available, and if people have questions afterwards, I'm happy to follow up later. So, we all know that rural residents face access to mental health services. That's not new information to anyone. But CAHs, since are ideally positioned to help fill this space a bit, because 60% operate at least one RHC, and they receive cost-based reimbursement for direct services provided by doctoral level psychologists and licensed clinical social workers. They also receive cost basis for the mental health services provided by physicians, nurse practitioners, PAs, clinical psychiatric nurses, and the like. So it's a great program. And RHCs can also get some enhanced reimbursement for different levels of master's trained clinicians that wouldn't be covered under Medicare. And I won't talk about methods because nobody cares. And what we found, though, is among 126, we analyzed cost reports, and within the population of CAH-based rural health clinics, which were about 1,300, almost 1,400, relatively small population are hiring psychologists and social workers, and that's about 126. So somewhere, very small percentage. So the goal is, how do we figure out how to get more of them to do this? What we found is that the clinics that are offering these services tend to be larger than those that don't, by a significant factor. And I want to really spend more time talking about some of the issues and how to go about doing this. One of the advantages to know is that since critical access hospitals are under, by the definition, are under 25 beds and smaller, they're not capped. The larger hospitals that have clinic provider-based RHCs are limited to $80-some-odd per visit. This is not the case for CAHs in their clinics, so it can be a financially sustainable service. So there are a couple of elements. As we go through integrated mental health services, a couple of points. We tend to treat and talk about mental health services as if it's a homogeneous whole, we're not really talking about programs for taking care of individuals with serious and persistent mental illness or children with serious emotional disorders. We're talking about the day-to-day things that many of us suffer from: depression, anxiety, stress, that can be done in a primary care setting. So as you think about moving forward with integrated care, some of the things to worry about, define and think about before you go, and these are sort of key decision points. What are the roles for clinicians? Do you have a team-based culture in your RHC? If you do hire mental health clinicians to provide these direct services, how will they be integrated in the team? How will you supervise them? Thinking about medical records, will they be shared or separate? I've seen both done where there are two separate sets of records, or those that are combined through an electronic health record with an ability for certain individuals to access the information. How is the goal is around the shared decision making. So if you have a family physician who's prescribing an antidepressant, for example, and a social worker treating through psychotherapy the depression, how is decision making being made? How does the team get involved? How is patient input being obtained? And what are the differences? How do you negotiate the differences? What are the treatment plans? Is there a common treatment plan? Who develops it? So and how is that oversight responsibility? These are all things that go towards making the service work better. Thinking about communication pathways. Do you have critical pathways or practice guidelines? If you do, who develops them? Who reviews them? Is there an internal referral process? Are all patients routinely screened for mental health issues? When a decision is made, is it internal? Or who decides if an external referral is needed? Is there follow-up, and is there any feedback to the referring clinicians? As we get into sort of the structural points of view, where's treatment being done? Is it a shared space, shared waiting rooms, or is it separate? Do you have a way of engaging the clinicians in the practice? Are there shared billing and scheduling systems? And then you think about who bears the risk for the service. So a lot of this is, we've done for a long time. And so if you work through these things, you can make a decision. Now, one of the last decision points that I think that it's important to think about is who you're trying to serve. There are arguments that can be made either way. Are you serving only those patients within those individuals who are currently patients of your practice? There are a lot of practices that feel that if they opened up the service to the community where there's already a shortage of mental health services, they might not be able to keep up with the demand for their own patients. So to access mental health services, you have to be an existing patient of the practice. Others will open it up if they have the sufficient resources to allow a patient to be referred from another practice. Neither one of these points are necessarily right or wrong, but it really depends on what your resources are within the clinic and how that can be done. We've also found that it is really necessary to sort of walk through that internal process and do a fair amount of training for the staff. Not surprisingly, people have varying levels of comfort with people with mental health issues. But to the extent that they understand that it's not really that different for most of us than any other health condition or disease, that they can learn to become comfortable with it, but it takes time to actively manage them. So we're going to talk about a few models, and I want to leave a minute or two for questions. We interviewed 11 CAH-based mental health programs. We talked to the physician staff. We talked to the administrators. So the one in South Carolina is the Abbeville Area Medical Center. They're an independent CAH with 2 RHCs, both providing mental health services. They employ 2 LISWs, which we talked about earlier. They have a board-certified psychiatrist and an administrative assistant, and they provide traditional counseling medication management services. We also talk to folks at Adventist Health in Clear Lake. This is a big system. They have 8 rural health clinics, and they employ 3 psychiatrists, 5 licensed clinical social workers, and a psychiatric nurse practitioner. They also use several case managers to address the social determinants of health. And by that, I mean transportation, housing, and a variety of issues that are complicating factors to mental health problems. In the Asperus Ironwood Hospital in Michigan, they employ 2 clinical psychologists, a psychiatric and a psychiatric nurse practitioner. And they have patient demand that exceeds staff availability. So this is a situation where it's important to understand what the demand is internally and what the demand is externally so that you can meet the goals for the practice. The providers offer counseling, psychotherapy, and psychiatric medication management. And as I go through these, you'll see that they're in various sizes, and I don't want to spend too much time because we're running a little short. We have Bingham in Blackfoot, Idaho. They have a psychiatrist, 4 social psychologists, and licensed clinical counselors. Part of I think, take a moment is you'll notice that we've used LCSWs and licensed counselors. Medicare will only pay cost basis for an LCSW or a clinical psychologist. But Medicaid programs will pay for a different range of master's prepared clinicians. So it's important to look at your practice space. If you have a heavy or predominantly Medicaid population, then it might be worthwhile hiring a licensed clinical professional counselor. But if ideally, in a perfect world, an LCSW is the most practical because that individual can be reimbursed by different programs, including Medicare. So a lot of this is decision making that you need to do. Let's see where, because we're running a little bit short, so I just wanted to skip ahead and just make sure I can cover a couple of things. Livingston Healthcare in Livingston, Montana, they have a psychiatrist, a psychiatric trained clinician, 2 LCSWs and a nurse coordinator. The psychiatrist and the physician assistant provide med management and consultation. The LCSWs do short-term psychotherapy and counseling, and the nurse coordinator offers case management. Now, the psychiatrist is important to realize it's nice to have because they have the capacity to treat more complex patients than a primary care physician or a nurse practitioner or PA might. But it is also difficult to hire that one, so that type of clinician. So a lot of it depends. So many family docs are comfortable prescribing certain types of medications. So what we see within these groups is a psychiatrist will do more complex cases. They may consult on a patient during the early days of treatment while the treatment plan and the care plan is being developed, and then shift that responsibility for ongoing prescription management back to the family physicians and the PAs and their practitioners with some consultation. And I'm looking for Pagosa Springs in Colorado. It's just an example of the fact that you don't need to be a large system to do this. They have an 11-bed critical access hospital with an on-campus rural health clinic. They employ 2 LCSWs, a licensed professional counselor, and a clinical psychologist. And so they handle much of their own work internally, but for urgent needs or after-hour needs, they have the ability to do emergency consultation via telepsychiatry with an external provider. And I'm going to skip to the final lessons because I know we're running short of time and I don't want to hold you. The thing that is important to know is that mental health services, most of these clinics reported that their services were financially sustainable and viable over time. And they, both from a fee-for-service standpoint, but particularly when you consider the impact on system performance rather than the standalone health system. And by that, we mean that patients with unresolved and untreated mental health problems will take more time for their clinician, from their family physicians. They visit for more often for pain issues and other problems. And so this has allowed their family physicians to be more efficient, and it's reduced the amount of time spent caring for those individuals so they can see more patients and have more patients come through the door. So it's a win-win. So it's not just the financial viability that's important from just a fee-for-service basis, but if you look at the performance of the system as a whole. Our clinic providers reported consistently they were satisfied with mental health services. They believed it helped to overcome stigma in the community, which is something that Dr. Vicente mentioned, and some of the other barriers that prevent patients from receiving services. And finally, it's really important to understand all the third-party regulations, policies, and payments. It's more than once we've heard that clinics hired a certain type of staff person only after the fact that they realized that Medicare or Medicaid might not pay for those services. So understand the rules and regulations, become very good friends with the code book, and for at least some programs, you're going to have to move away from the ICD-9 to the DSM-5. I will end there. So my co-authors and my contact information, please, if you have questions, feel free to reach out after we're done.
Excellent. Thanks so much, John. There is a link in the chat to the full article that can be found on the Flex Monitoring Team webpage. So I'd like to just take a minute and thank each of our presenters, Dr. Vicente, Kenesha, and John Gale, too. We really appreciate you sharing this information. I think lots of practical information that we can take and either suggest to our clinics, in our hospitals that we're working with, or just interpret how we want to run our Flex programs to provide the right services to our entities that are all across the nation working to address these issues that are even more compounded now with the different disparities that are certainly coming to light in our country, and then, of course, the pandemic sitting on top of all of this. We unfortunately don't have a lot of time for questions because I want to make sure that everybody gets a break and gets into the next set of breakout sessions, too. So if you have questions, I know contact information has been shared, so I encourage you to follow up with the speaker separately, or us in task, we can facilitate that. In the chat box now is a link to each of the next 3 breakout sessions, so I encourage you to check the agenda, but I can also tell you quick what each of those sessions are about. So session 4A is about rural hospital closures. Session 4B is about using Compass and the financial data within Compass. And then session 4C, which will happen in this same exact room, is the MB Quick 101. So you can stay in this room if you're interested in that. Otherwise, the links are there, and we will get going with those again at 12:20. Thank you all.
Thank you.